My name is Joseph Duraney, and I am a congenital heart surgeon at the Mayo Clinic in Rochester, Minnesota. I'd like to introduce my friends here.
I'm Ram Imani, and I practice at Boston Children's Hospital in Boston.
I'm Tom McGilvery, Massachusetts General Hospital in Boston.
I'm Vaughn Starnes, Children's Hospital of Los Angeles and the University of Southern California.
I'm Jim Tweddle from the Children's Hospital of Wisconsin, the Medical College of Wisconsin in Milwaukee.
I'm James Jaggers. I'm a congenital surgeon at the University of Colorado and Children's Hospital of Colorado.
Well, I'd like to welcome my friends and colleagues here who are all congenital heart surgeons and care for patients in all age brackets from the newborn on up into the adult years. We are going to focus our discussion today on the adult with congenital heart disease, which is a really growing patient population. In fact, there are more adults with congenital heart disease now in the world than there are children with congenital heart disease. And that is in large part due to the wonderful and great successes that we've had in the 70s and 80s with excellent outcome for correction of procedures in the newborn period and in the period of infancy, such that the majority of these patients have lived well into the adult years. And some additional problems may have occurred that require intervention. And this is the topic that we are going to focus today. Training residents is changing right now in terms of how we educate the surgical resident. And everybody here is an educator, and I think it would be important to hear what we're doing in Boston. Ron?
Well, we're uniquely positioned because as a children's hospital next to an adult training center, we get a lot of residents that cross over at various times during their training, particularly during their early in their careers when they're getting exposure to adult cardiac surgery. They come over and spend at least 6 months with us. The first 6 months is spent learning the lingo and learning how to even think about congenital heart disease. And I think it starts with having adequate amount of time for people who are going to be trained to do both adult and congenital heart disease to really understand the nuances.
Tom, you're in Boston at a different institution. Is the strategy similar there? It's different?
Right. Certainly, medical education has changed over the last several decades, and we're continuing to try to balance the principle of graduated responsibility with the new milestone project. So we've continued to try to help the residents learn from a point of view of the technical aspects of surgery as well as learning the cognitive aspects of patient care.
You know, Jim, you represent the American Board of Thoracic Surgery. I mean, what are the rules and regulations for somebody to practice congenital heart surgery, and who should be doing it?
Candidates gain eligibility to sit for the special certificate exam by completing a 1-year fellowship in congenital heart surgery. And they have to have complete certain case requirements so that this is really a meaningful year of both educational and surgical experience that will prepare them for a career in congenital heart surgery. But I think you raise a good point that congenital heart surgery is now a changing field. Whereas in the past, we dealt primarily with infants and particularly neonates. Now we're starting to see more and more grown-up congenital heart disease, and we'll have to adjust to that changing landscape, and training will have to include experience in that population as well.
Joe, if I had just a slightly different perspective, is that I'm probably one of the last dinosaurs to do both, operate on children and adults. And I think what it's allowed us to do in our program is, with a freestanding children's hospital, we have a congenital fellowship, but all of our residents in our adult training program rotate through it. And we've actually trained one of our adult surgeons who did a year of congenital heart, who's now one of our primary adult congenital heart surgeons along with myself. And I think that's a model that's worked out very nicely for people who want to do adult congenital heart disease, because I think it is different. And one of the differences, I think, is just having residents, particularly when they talk to cardiologists, just understanding pulmonary vascular resistance is a big thing for people, because we deal with adults now with pulmonary insufficiency, how much regurgitation is important or not important, when should you put a pulmonary valve in. And I think our pathways in the future have got to include both training not only of our adult congenital surgeons, but also of our adult cardiologists.
So you've all touched on a couple points that I'd like to expand upon a little bit. Let me just ask Jim, do you think adult cardiac surgeons should be taking care of these patients or congenital surgeons, and what would you think would be the advantages and disadvantages?
I think this is a particularly vexing problem because all of us have been trained predominantly in adult surgery and congenital surgery, but the next group of trainees is going to actually be trained in congenital surgery in predominantly children's hospitals with particularly young patients. Whereas now, in the private sector essentially, or in some of the more adult populations of practices, they're not trained either. So there's going to be this gap where we're not going to have the appropriate training in people, in surgeons to take care of them. So I think what we're going to have to do is develop some kind of a track, if you will, within our own specialty in which you, like Vaughn said, is you bring them up from your own program, and they get trained in adult and kids, and then they designate themselves to become the adult specialist within your own group. That's the only way I see that we're going to cover it. Now, the bigger question is there's competition out there now for these patients. There's competition for the pulmonary valve patients out there. There's competition for the ASDs. A lot of VSDs are closed by adult surgeons out in the private communities. So what's going to happen to those patients as the older surgeons move on and then the younger ones are not trained in pulmonary valve replacement? That's going to be an interesting problem.
Well, there's a fair amount of data out there now that actually would indicate that the outcome of the management of adult patients with congenital heart disease is actually superior when the personnel are trained in congenital heart disease, beginning with the surgeon and moving on into the other specialties. I'd like to, you also, all of you alluded a little bit to the challenges with hospitals and the location, and maybe we could see what the varying practices are in terms of whether these adult patients should be cared for in a children's hospital or whether they should be cared for in an adult hospital, or maybe there's a place for a little bit of both. Ram?
Well, I think this ties in very well to what you talked about, Jim. A lot of what happens around the care of the adult patient doesn't just involve the surgeon. It involves multiple specialties, and it involves really centering a program around the patient and not around the silos of individual specialties. In Boston, what we have done over the past decade or so is to organize our cardiologists, our nurses, our intensivists, and our anesthesiologists into a program which really focuses on the complex care of the adult patient. Now, those patients don't necessarily need to be treated at a children's hospital. They can get triaged based upon their disease to either an adult hospital or to a children's hospital. But both parties are at the table and talking about the complexities of those patients together. And I think a lot of the advantage of having a person trained in congenital heart disease to think about these patients is really that microscope and saying what has been our experience with these patients in the past, when there might be a very few number of patients that come through, and really being able to bring upon that institutional memory and bring upon knowledge from other locations and really concentrate those in the care.
I know, Vaughn, you've thought about this a lot. I've heard you speak on it. What do they do in Los Angeles?
At the University of Southern California, where Children's Hospital is one of our teaching hospitals, our model is different, and I think it can be done depending upon your hospital setup, either way. But at USC, we've decided to move our 18 years of age and older to the university hospital, but we've done that in conjunction with our pediatric faculty. We felt like our freestanding children's hospital was so remote from our adult hospital, it would be hard to get, as Ram, I think, was alluding to, all the adult specialists over to take care of adult patient problems. In addition to congenital heart disease, you suddenly have diabetes, you suddenly have renal failure, you suddenly have pulmonary diseases. You can even have coronary disease in some of these older congenital heart patients. So we felt like we did not have the adult specialties represented at our pediatric campus to take care of them. So we made the conscious decision to move those patients to the adult hospital in conjunction with our pediatric faculty and bridging faculty. We have several pediatric cardiologists now that have trained are on our adult faculty who help us with our adult congenital program.
And when you say help, are you talking about doing cases together? I mean, I do think that there's a place for collaboration between the pediatric heart surgeon and the adult cardiac surgeon. I think coronary diseases would be a classic example. There's not a lot of pediatric heart surgeons that are really comfortable doing coronary bypass surgery. There are some. I know you are one of them. But are you talking? Tell me what the collaboration would entail.
Well, I think the collaboration's really important for our residency training program, both on our surgery and cardiology faculty, because our cardiologists, pediatric cardiologists, can come to the cath lab, take our residents to shunt calculations, pulmonary vascular resistance, and understanding the physiology. Prior to our starting this program, I would send a congenital case over. I would get beautiful coronary arteries. I'd get nothing else. I'd have a hole in the heart, have a shunt. No one did a shunt calculation. So what I mean by collaborating and helping, I've got expertise there now that'll teach the adult faculty and the residents what's important to look for in working up a patient with congenital heart disease.
Now, Jim, we're talking about collaboration here, and I know that you, in your practice in Milwaukee, you have made a lot of contributions with the critical care personnel and what you've been able to do with patients and getting them out of the hospitals and monitoring. Tell us a little bit about the importance of the multidisciplinary approach to caring for these patients, and what do you think would be the most important things for somebody trying to get a program off the ground to be aware of?
I think that's an excellent point. I think the days where the surgical team could be in charge of every aspect of care are past, and we have to work in a collaborative environment where cardiology, critical care, anesthesia all have input and help in the management of the patient. So I think that's an excellent point. This goes into the decision making in our case as to exactly the location of the surgery. There, we try, I think, in most cases, to do the adult congenital cases in our adult hospital, which is immediately adjacent to the children's hospital. But in some cases, for example, a Fontan conversion where the physiology might be a little bit more challenging for the adult ICU, we would do that patient in the children's hospital. And I think it goes to the point you said about the cath lab and so on. This where the adult specialists sometimes have a hard time grasping the physiology and anatomy of congenital heart disease, and this is a process in evolution. I think is the whole sphere of adult congenital heart surgery is an evolution.
So maybe I could ask Tom and Ram a question about the challenges of trying to manage patients of this complexity in different hospitals. And you both are in Boston and in different institutions, and you may be conflicted about doing a patient in one hospital, but your practice is anchored in another hospital, and the comfort level of leaving somebody else in charge. What is your position on that?
Well, I think as Ram alluded to earlier, that the performance of taking care of these patients, if you will, I think depends not so much on the stage, but the cast on the stage. And I think that in many ways that our patients have benefited from the successes over the years of treating congenital heart disease, and that what used to be once a disease of children, and hopefully they'd grow up to be adults, now they're thriving as adults. And so there's a mixture of taking care of diseases that started in childhood that now have morphed into an illness or a condition that is now not only in the adult, but also they now develop other adult-type problems and diseases. So I think that the patients would benefit from bringing together healthcare specialists who are expert in taking care of children and experts in taking care of adults. And I think that we can all learn from each other to the benefit of the patients.
To me, this is one size does not fit all here. I mean, what we have in Denver is going to be different than what you have in Boston. And to me, this is a lot less about the surgery itself. It's less about the operation than it is the pre and post-op management and care. For example, it's the electrophysiologic problems that these patients have. Now, we particularly have good electrophysiology at our university hospital, but then we prefer to do the surgery at the children's hospital. Well, you do an EP procedure on somebody that has sustainable VTAC, and they have to stay in the hospital until their operation, then what do you do? So we've created a system in which, somewhat arbitrarily, we have decided that if you're going to have a surgery at the university hospital, then you're going, or if you're going to have an EP procedure at the university hospital, you're going to have your surgery there. And if you're going to have your surgery at the EP procedure at the children's hospital, you're going to have your surgery there. Taking advantage of the best capabilities of each program. I'm less about saying age less than 30 goes here and more about, and age over 30 goes here. I think it has to be patient-centered, it has to be disease process-centered, and I'm doing a 44-year-old patient in my children's hospital next week. He has no comorbidities, and he wants to have it done there. Did an 18-year-old at the university hospital, 2 weeks ago. I think it's fine either way.
I also think what Jim and Tom have both alluded to is it's much like TAVR. The government actually mandated a team approach. And I think that's really important in adult congenital heart disease. It's not about the surgeon or the cardiologist. It takes a team. It takes ICU people. It takes surgeons. It takes cardiologists. One of the things we may not want to face that is coming is that we were able to control that a little bit when a lot of these individuals did not have insurance.
That's right.
They're going to have insurance in the future. And there's going to be a lot of people out there who suddenly said, we'll take care of those patients now. And as a team, they're not prepared to. I think the onus is going to be on us to sort of try to figure out how we're going to handle that question. Because I think Medicare, from what I heard of the talk this morning, would like for us to handle that question before it becomes a real problem.
I think a programmatic approach involves not only having individuals that have an interest, but having structure to it. I mean, that's one of the things that we found. We have weekly meetings of the adult congenital program, and we may not necessarily have a patient to discuss, but as with weekly conferences, which I think a lot of programs have gone to instituting, we force ourselves to look at specific issues surrounding patients with adult congenital disease. We sort of tag our identity as being specifically dedicated to this population, which I think brings a new culture and a new flavor to the mix. And we have a lot of interaction with our adult colleagues. At some point, the lines blur, and as they're blurring, even in between cardiologists and surgeons. And I think really putting form into that process is automatically going to follow through with, not only from the standpoint of what you do with a specific patient, but also in terms of really mining data and saying, well, what do we know and what can we answer with just being on the cusp of patients that are entering adulthood.
So maybe we shift gears a little bit here. It just made me think of another issue. So all of us operate on children, and all of us operate on adults with congenital heart disease. And now that we are appreciating the fact that almost everybody is living into the adult years, how do you counsel the parents of children now that are having surgery in terms of what they should expect? Because if you look at the range of operations that we have in the adult age group, we have, most of them are reoperations from lesions fixed earlier on in childhood, and there's a few that sneak through that have been undiagnosed. But has it changed the way that you counsel parents and families in terms of what the long-term expectation, recognizing that just about almost every lesion may need something down the road, from an arrhythmia or a residual hole or a valve problem? What do you guys do?
I'll back it up even a second. I find that there's a lot of inconsistency in terms of when patients are referred for surgery, and I find that to be one of the biggest gaps. A lot of them get lost to follow-up. Adult cardiologists or either pediatric cardiologists may have a different view on when a patient really needs to come to an operation. And one of the things that we've done to try to mitigate some of that is to develop standardized clinical assessment and management programs. Actually, patients who've had arterial switch operation undergo a standard form where they have to get the clinic visits every so many years with echoes on visit X, Y, and Z. collecting data on a lot of these patients to see, for example, how many of them develop aortic root dilation and how many of them develop complications. So we can start to wrap our heads around the disease process before we even get to the point of saying who needs surgery and how.
Well, one of the, just take a common lesion that we all see is tetralogy of Fallot, as it speaks to your question, Joe. You sit with a family and it's got the child's got a pulmonary valve of Z-4 or 5, and you think to yourself that that's probably going to be a valve you got to put a transannular patch in. Then you have a different discussion with that family, because that family has to have realistic expectations that this is not the only operation the child's going to have. You prepare them for the next stage and whenever that might come. And we don't know oftentimes when we do a transannular patch whether it's going to be a year from now or 5 years from now or 15 years from now. But what it does mean to the parents, and the parents have to relate then to the child as the child grows up into the adult years, that they're going to need constant follow-up. They can't be lost to follow-up because they've got lesions that will always need some oversight and looking into. So that's how I changed my conversation.
Jim?
I agree with that 100%. With the exception of an ASD or a VSD, the conversation always ends with your child will need to be seen by a cardiologist throughout his or her life. In the past, I think we were optimistic that we were rendering a cure when we take a patient in the operating room, but it's clear that reoperations and reinterventions are going to be necessary.
This is particularly important for the age group of the teenagers. And that probably gets to another point about, we're giving them advice, but the cardiologists are predominantly the ones making the decisions. And so, I don't know when is the right time for pediatric patients to transition to their adult congenital cardiologist, but probably somewhere in that late teen years to early 20s before they get lost to follow-up, before they get to college, before they lose their insurance. And that's the time at which you can reinforce that, you're not done. You're going to need something else. And if you, when they're starting to get out from underneath their parents' rule and getting on their own, they got to be reinforced.
The message needs to be lifelong surveillance, lifelong management, and the best way, of course, would be for us to provide a structure that allows that to happen seamlessly. But they do. I stress with the parents that it's a lifelong process that will require management and sometimes likely other interventions.
I think, if I could just add one thing, I think that as thoracic surgeons, we've grasped this issue, I think, fairly well. We've always taken care of both the pediatric and adult patient with congenital heart disease. The real challenge now is going to be on the medicine side of this equation. And training is not quite as standard.
Yes.
And certification is. With your contribution to the American Board of Thoracic Surgery requirements for congenital heart disease, we've made it certain now that patients will
Residents will get the right exposure. Sure.
That we made it certain that residents will get the proper training, and as Vaughn spoke about, especially training individuals in adult congenital heart surgery is not a great leap for us as I think creating a mirror image in the medicine side.
But don't you think, too, Jim, that it's also getting all of our colleagues in nursing and social work and everybody that's essential in taking care of these patients, because that one thing that we've learned is that there are a lot of social issues that are important to help our patients take care of through a lifelong process.
Absolutely, they face all the challenges every other child and teenager and young adult has, plus the burden of surviving congenital heart surgery.
So maybe this has been a wonderful discussion. Maybe I could just summarize some of the things that we talked about. So first, we're at the Society of Thoracic Surgery meeting, and fortunately there have been a number of things on this program that have addressed this very issue, adults with congenital heart disease. So I've learned from our conversation that children have a very promising outlook when they have their operation in childhood. And actually, this is a good problem for us that everybody's getting into the adult years. And we continue to refine procedures to minimize that, but children, for the most part, are doing well. Secondly, there are more formalized education pathways that we have taken ownership of on the surgical side. We have a certificate that is required for us to practice this specialty. I think the differences between where we take care of a patient, whether it be in a children's hospital or an adult hospital, it sounds like looking at the different geographic areas represented here is going to be specific to the local institution and the local environment. It may be at a children's hospital in one place, it may be an adult hospital in another place, and it may be some patients in one or the other depending upon the problem. But the experience and the education of the personnel is really the bottom line to make sure that the right care is rendered. And finally, the lifelong surveillance for many lesions really cannot be overemphasized for many of these children. So would that be a relative accurate summary? Any other
Great
closing
job.
comments? Thank you.